Hi, Mike Gibson, Pam Taub, and we're talking about how you can track the plaque in your body. Pam, we focus a lot on looking good on the outside. So many people now are on weight loss drugs, looking good on the outside, but they may be looking good on the inside. So we have some new powerful tools to take a peek under the hood. I know for me, I had a CT angio, and it was very helpful for me to visualize my own arteries. And it really, that kind of picture can really motivate people. So, Pam, can we really make our insides look better? I mean, can we get rid of plaque or stabilize it? Talk to us a little bit about what are some of the things patients can do to make themselves look not only good on the outside, but on the inside.
Well, you touched on a lot of great topics, which is that there are some people that even though they look great on the outside, they may be extremely thin, they look fit, but internally they have a lot of atherosclerotic plaque. Their cardiometabolic profile is abnormal. And so you can't just judge a book by the cover. You do have to look inside. And we now have incredible tools including CT coronary angiography with plaque analysis that allows us to look deeper and look on the inside and look at the atherosclerotic burden. And for many patients, it's very motivating to understand the degree of disease that they have and to also monitor changes in that disease with appropriate therapies. And that includes both lifestyle and pharmacotherapy. And I'm a big believer that you have to do both. It's not one or the other. For most people, it's both. And there's an incredible synergy between pharmacotherapy and lifestyle therapy.
So, what are some of the things you can do in terms of lifestyle? We'll talk about maybe smoking first.
Well, I think that's one of the best interventions that we have shown decreases plaque. So when you smoke, you have abnormal endothelium, and smokers have a higher rate of cardiovascular disease. So quitting smoking is a very powerful tool to decrease risk. But there's a lot of other things we can do from a lifestyle perspective, and that includes eating well. And the diet that has the most evidence-based is a Mediterranean diet. And one of the things that I tell patients is to really look at the composition of their food, making sure that they have good protein intake, good fiber, good carbs, and making sure that those are well balanced. So the Mediterranean diet is an easy to adopt diet by many people. And so that's a very good way to make a lifestyle change. But then there's also exercise that needs to be incorporated into everyone's regimen. And then there are other therapies, such as the GLP-1 receptor agonists that you mentioned that help with weight loss. But there's also anti-inflammatory therapies that we will use for some patients. And if you have diabetes, the best agents for diabetes that modify cardiovascular risk are the SGLT2 inhibitors, as well as the GLP-1 receptor agonists. So this combination of both lifestyle and pharmacotherapy can be very useful in causing plaque to melt away or regress.
So, I looked at those plaques for, gosh, 35 years now using angiograms, squirting some dye down the arteries. I was looking on the inside of the artery, but what has been so revolutionary is the new technologies that look at the wall of the artery, not just the amount of narrowing at that one point, but all the plaque everywhere throughout your arteries. So, talk to us about what we can learn from CT angio.
Well, angiography, as you mentioned, it has been our gold standard, and it's really looking at luminal stenosis. But the artery is very smart. And when you form plaque, there's eccentric remodeling of the artery. So initially, you may not see any luminal stenosis, even on an angiogram, but there is plaque, and that plaque is very sneaky and hiding in the wall of the artery. And this is where technology like CT coronary angiography really allows you to visualize that plaque that you would miss on angiography, and you would definitely miss it on stress testing because it's not causing a hemodynamically significant stenosis. And so this is really important because most myocardial infarctions aren't occurring at lesions that have a greater than 70% luminal stenosis. It's the lesions that are less than 50% that we're not picking up with conventional angiography or stress testing that are leading to future heart attacks. And so this is where CT is very useful. And I think this is the tool that we're all going to be utilizing for visualization of subclinical atherosclerosis and for prevention of future events. What we've also seen is that plaque that's hiding in the artery can regress. So we used to talk about plaque stabilization, but now the new paradigm is plaque regression. And we've seen in studies such as Huygens, Pacman AMI, where we get the LDL to very low levels, that there's actually decrease in the atheroma volume and plaque regression, which is what we want to be aiming for. And one of the great aspects of CT is we can actually track that over time. We can tell a patient, you have plaque, let's make these changes, both lifestyle and pharmacotherapy, and then let's reevaluate in 2 years and see what's happened. And I think that serial tracking also provides that patient with a lot of motivation to continue with everything that they're doing.
My pathology professor teacher in medical school was Seymour Glagoff. And what you're describing is the Glagoff phenomenon, where the artery actually doesn't narrow, it actually gets bigger. The fat is on the outside till it gets about 40% fat. Then it starts to grow inwards. I spent 3 years of my life staring at the lumens of angiograms, trying to make plaque dissolve, and nothing really happened. It got better by 1%. It was really kind of disappointing. But we didn't look at the wall. So the wall has a lot of the action. And, it's not just the amount of plaque, it's what's in the plaque. People focus so much on their calcium score, but it's the fat in the plaque, the soft plaque. So we can really characterize that kind of risky plaque now, right?
No, I think the plaque characterization is a game changer because not all plaque is created equal. So you can have non-calcified plaque or you can have calcified plaque, and calcified plaque is much more stable. And there's a lot of patients that will have a 0 coronary calcium score, but will have a lot of non-calcified soft plaque. And so this is where the technology helps us identify those at-risk patients.
Yeah, not just the extent, but the type of plaque. So, Pam, how are you using this in your clinical practice?
So I think the art of preventive cardiology is the detection of subclinical plaque. I find no satisfaction in treating a patient after they've had an acute myocardial infarction or a stroke. I think that's too late. What we want to be doing is detecting disease early. And I think this is where CT coronary angiography with the plaque analysis is very helpful. So I do use this in a lot of my patients that have high risk features. Some of them have elevated lipoprotein A, strong family history, metabolic syndrome, and I use it to detect plaque. And it's really surprising. Some of the patients that you think would never have any disease have significant disease. And so when we detect disease, that's when we have to implement a lot of therapies, both lifestyle and pharmacological. And then I will use it serially after I've detected disease to see how am I doing in transforming plaque. I mean, the goal is if there is soft plaque to have that regress and also to have some of that transformed into calcified plaque, which is stable. So it's like a report card that I can do every few years to see how we're doing in terms of managing plaque.
Well, my own story, I was going to start working out again. I played college football, was going to start working out, got that CT, that calcium score was really high. And then we got the CT angio, and then we got the plaque analysis. And what we found was even though I was on, high dose atorvastatin and ezetimibe, my calcium score was really high. And that led to LP little a testing, and mine was very high. So it really did change my care. I'm proud to say my LDL is 19 now. So I've really changed things. I lost weight. So you can do it. You can change things. You can make those arteries look just as pretty as you do on the outside. So, Pam, thanks so much for joining us today. Thanks for sharing how you're using this in your practice.